So thank you very much. Let me begin by expressing my gratitude to Sanjay, Michael, and all my friends at CRI for including me in this fabulous afternoon session. As mentioned, after 20 plus years of life and work in Boston at Harvard Medical School, I've recently relocated to Lausanne, Switzerland. So this will very much be a talk with an American perspective provided by a newly anointed European. So I've been asked this afternoon to talk about COVID-19 infection and to address the question, should we be worried about athletes that contract the virus? Here are my financial disclosures, teams with which I have affiliations, and also funding sources for my work, some of which will be included in this talk. So here's the question: COVID-19 infection in the athletic heart, should we be worried? And just to cut right to the chase, here's my answer. Yes, but not nearly as worried as we once thought we should be. And so this talk is really a historical journey about COVID-19 in the athlete's heart, moving from the concept of an emerging public health crisis to a manageable clinical scenario. To begin with, let's go back to the very early days of the pandemic. Long before COVID ravaged Europe and the United States, we learned a lot about this disease from the sentinel case reports that emerged out of the Wuhan region in China. We knew that this disease was one that was largely contracted in group settings, either public spaces or among families, that the common symptoms of this illness included fever, cough, myalgias, fatigue, that the illness was typically characterized by an onset from the development of viremia to the presence of dyspnea by about a week, and that in a small but appreciable subset of patients admitted to the hospital, there was a higher than expected prevalence of acute cardiac injury. We also learned that the nature of this acute cardiac injury, at least as measured by circulating troponin elevations in the critical care unit, was not benign, and that the patient substrate going into infection was an important determinant of outcomes. These again are data coming from the Wuhan region of China, which demonstrates that the presence of underlying cardiovascular disease coupled with the presence of an elevated circulating troponin during the time of acute infection portrayed a very bad outcome, in contrast with those that had no cardiovascular disease and normal troponin levels. So where were we early in 2020 when this pandemic first began? I think the European and the American experience were largely similar to one another, and what we remember was a period of shock and disbelief. We saw schools and universities closing, we saw restaurants and bars shuttering, we saw elective medical procedures canceled, and we saw elite level sports obliterated. So what did the obliteration of elite level sports look like in the United States? This was a staggering sequence of events. On March 11th, 2020, a basketball player by the name of Rudy Gobert, who played for the Utah Jazz, was diagnosed with COVID, and immediately the NBA suspended the rest of their season. The following day, Major League Soccer, the NCAA basketball tournament, the National Hockey League, and the Major League Baseball canceled their activities. The following day, we canceled the Boston Marathon, which was scheduled for the month prior. And then PGA, NASCAR, contact sports came to a close. And finally, within 5 days, the Center for Disease Control ordered cancellation of all events, including greater than 50 people for 8 weeks. So sports as we knew it came to a close. Early in the pandemic, as we were sitting there scratching our head thinking about what to do, we began to learn about how COVID-19 impacts the cardiovascular system. And it was from elegant, multi-center, multinational autopsy series such as this that we learned some important diseases about the heterogeneity of COVID infection injury. We learned that COVID-19 in sick people caused hemodynamic injury, that there was cytokine-mediated injury, that there was direct myocardial viral invasion, and that all of this, when superimposed on underlying cardiovascular disease, was a larger problem. As a sports cardiologist, and as many of you will realize, that the pathologic finding that caused the most concern was that of lymphocytic myocarditis. Now, well before COVID-19, myocarditis was recognized as a cause of sudden death among otherwise healthy young competitive athletes. And so the pervasive fear when we started learning about the propensity of COVID to cause myocardial inflammation is that we would be seeing an emerging public health crisis. This led to what I believe was the first ever attempt to put together an algorithm for bringing athletes back to the playing field, or at least back to the training venue after COVID-19 infection. This is a busy chart, but I'll just boil it down into several key points for you. The first idea was that there should be some tiered approach to post-infectious pre-participation evaluation, with the sicker athletes getting the most testing, and that this should largely be guided by the concept of pretest probability of disease. that those that present with symptoms, particularly symptoms suggestive of cardiovascular involvement, were the ones that were the most likely to harbor inflammatory disease and were the ones that were most likely to require the most in-depth evaluations. But most importantly in this initial piece was the following, and that is that the fundamental questions that would affect millions of athletes worldwide and ultimately help us prevent unnecessary loss or life would only be answered by the sharing of experiences and the pooling of rigorously collected data. So the initial thoughts put forward in the BJSM blog piece that a number of us put together were quickly translated into the first ACC-AHA algorithm for the assessment of the athlete after COVID-19 infection. And again, all of these algorithms are quite busy and difficult to interpret, but I want to point your attention to what I think is the most important part of this algorithm. And that was the approach to mild symptomatic patients that were not sick enough to be hospitalized, but that did have symptoms associated with disease. And the idea then was that if you were sick enough to have symptoms, there was a high enough likelihood of underlying myocardial inflammation that some testing should be done. And after a lot of thought and consideration about all of the possible tests that could be provided to these young athletes, the concept of the triad test evolved, which was the combination of high sensitivity troponin testing, a resting 12-lead electrocardiogram, and a standard two-dimensional transthoracic echocardiogram. Sports weren't down for long, and there was a good and very predictable reason for that. When you look at the infrastructure of sports and the finances associated with it, this is close to a $1 trillion global industry, with professional sports and the associated retail from that accounting for more than half of that. And when you look at where this revenue is generated, you can see that with the exception of the Premier League, of which I'm a huge fan in the UK, that a majority of this comes from the United States and Europe. In addition, in the United States, we have the added issue of collegiate sports, which are a huge financial revenue generator for a small number of schools with television rights and a lot of money at stake. So sports were not going to be down for long. So what happened when both the professional and the collegiate sports started going again? Well, we had an opportunity. We had an opportunity to test the protocols that we had recommended, and we did so. And so there was a lot of triad testing done among the professional athletes that came back to the pitch, back to the courts in July and in August of 2020. The vast majority of these athletes that had COVID-19 were either completely asymptomatic or had very mild disease. And with lots of testing, we found very little pathology. Now, there were exceptions to that. A good example would be Red Sox pitcher Eduardo Rodriguez, who was diagnosed with inflammatory heart disease and, as would be consistent with practice guidelines, was convalesced for an extended period of time. But also, as should come as no surprise after Dr. Papadakis' great talk earlier this afternoon, as athletes started playing sports again, we saw athletes succumbing to sudden death for non-COVID related reasons, which was a reminder that even when COVID-19 was surging, the usual causes of sudden cardiac death needed to be thought about and screened for. The experience with American professional athletes was published and put together by a group of us as a cross-league collaboration. This included approximately 800 athletes who all underwent the recommended triad test. 96% of these had completely normal test results and returned to play without any issues. The remaining 4%, which in this case it was accounted for by 30 athletes, had one or more abnormalities on the triad test. Each of these individuals underwent individualized testing as dictated by team physicians and sports cardiology consultants. And at the end of the day, the prevalence of acute COVID-related inflammatory heart disease was deemed to be 0.6%. And perhaps most importantly, all 5 of these athletes had clinical presentations consistent with their diagnosis, meaning signs and symptoms that any clinician familiar with this disease would pick up independently of screening. In this case, we thought about the testing less as a screening test and more as a confirmatory diagnostic test. So the pro sports experience was relatively straightforward. It was a little bit messier in the college experience, and that's because different college conferences took different opinions. And perhaps the most notable standout was one of the most prominent basketball and football college conferences in the United States called the Big Ten. And they made a very public and a very controversial decision to move beyond the triad test to include a mandatory cardiac MRI for all athletes as part of a screening test to receive clearance, and that this screening test could only be done at 21 days following a positive COVID-19 diagnosis. This was the first widespread clinical implementation of a screening protocol during COVID-19 using cardiac MRI. Fortunately, some of the schools that were involved in this effort were kind enough to publish their initial results, but I would say when these individual studies were looked at in pooled fashion, we were left with more questions than answers. The prevalence of modified Lake Louise criteria positive cardiac injury ranged from less than 1 to up to 15%. The prevalence estimates of pericardial injury range from 0 to 40%. And the incidence of isolated late gadolinium enhancement on the MRs of these college student athletes range from 0 to up to 46%. So most of us felt like our poor American buddy Homer Simpson there, scratching his head saying, where's the truth in all this? In an attempt to provide more granularity and an attempt to come up with better prevalence estimates and ultimately outcomes data, a group of us got together and formed the ORCA registry. The ORCA registry, which stands for the Outcomes Registry for Cardiac Conditions in Athletes, was formed by colleagues of mine at the Mass General, colleagues at the University of Washington that have a very prominent sports medicine program. And there was funding received from the American Medical Society for Sports Medicine, as well as the American Heart Association. This is the initial paper presented out of the ORCA experience. This was published in Circulation in April of 2021. What we did is enrolled collegiate athletes from 42 of the largest colleges and universities in encompassing 23 states and 14 athletic conferences. This included just shy of 20,000 athletes coming back to campus to play Division I varsity sports. Of that, approximately 18% had been positive for COVID-19. And the vast majority of these people underwent cardiac evaluation in some form. And I'll talk a little bit about that more in the next slide, leaving us with a final cohort of evaluation of just more than 3,000 people with diagnosed COVID-19. So here is the main finding chart from this paper. Indeed, among 3,000 athletes, similar to what we found in the professional cohort, approximately 96% of them had totally normal testing with no evidence of inflammatory heart disease. The remaining 4.5% could be divided into two groups. Those that had some cardiac abnormality that was definitively unrelated to SARS-CoV-2 infection. And this is the long list of things you would expect to find if you screened athletes with some form of non-invasive imaging, including both incidental things that require no follow-up and conditions like hypertrophic cardiomyopathy and aortopathies, which do indeed portend a risk of adverse events. But among those that had cardiac abnormalities possibly related to SARS-CoV-2, after further diagnostic evaluation, the true prevalence of either definitive, probable, or possible SARS-CoV-2 infection was at 0.7%, again, very close to what we saw in a totally different cohort of professional athletes. But indeed, the ORCA study was really two studies in one. It was a study in which we had the opportunity to include schools that were using MRIs as a screening tool. And it was a study in which we had schools included that were relying on the clinical standard at that point, which was triad testing. And as many of you would suspect, based on the use of different diagnostic modalities with different sensitivities and different specificities, when we looked at cases that we truly adjudicated as either definitive or highly probable cardiac inflammation, there was a 1.5% prevalence estimate among those with screening CMR, and there was a 0.4% estimate among those that were screened with the triad test. So different screening algorithms, different disease prevalence estimates, no surprise. I think at this point, the big question that we were all wrestling with was, were we missing silent and potentially lethal disease? Were there athletes that were screened by triad test that had myocarditis that would go back out onto the playing field and suddenly have adverse events? And perhaps even MRI wasn't sensitive enough to find small levels of inflammation that could do damage. Before doing that, I want to quickly talk a little bit about whether or not CMR should be used as a screening technique. And in my opinion, the answer is definitively no. Let's step back and remember that in order to get the superb diagnostic accuracy performance that we now have with the electrocardiogram, it took decades of work developing normative data, understanding reasons for false positive, false negative, true positive, and true negative tests, and looking at pattern by pattern to understand what should be considered normal and what should be considered abnormal. We are nowhere close with the cardiac MRI. It's costly. We have no normative data. It's not particularly reproducible. And while it remains the gold standard for diagnosis among individuals with a high pretest probability of disease, its use in the screening arena should at this point be put to rest. For any of you that are interested in hearing a little bit more, or reading a little bit more about this argument, I include here this reference to a piece that we wrote recently in the British Journal of Sports Medicine. Most importantly, though, is the issue of what's happening to these people. So again, among the ORCA cohort, 3,000 strong, we were able to keep close surveillance of these athletes over the period of the first year after they all came back to the playing field. This represents hundreds of thousands of athlete hours among people with definitive COVID-19 infection, and included a very small number of those that had myocardial inflammation and were appropriately treated with rest, recovery, and pre-competition testing to return to the playing field, but a large number of those that had no evidence of inflammatory heart disease following their diagnosis and were allowed to get back onto the playing field. Among those with inflammatory heart disease who were treated appropriately according to guidelines, there were no adverse cardiovascular outcomes, and all returned to sport successfully. Among the large cohort that were passed through the initial screen, there were 2 events that were recorded. One resuscitated event of sudden cardiac arrest that was related to an underlying form of genetic heart disease, and the second one isolated case of atrial fibrillation occurring several weeks after SARS-CoV-2, which indeed could very well have been related to the infection. So over time, what has happened is we've moved away from fear and phobia of this being a complication that affects the majority of young people with athletic interest to one that affects a very small number and one that can be dictated, determined, found, and treated with a simple pretest probability approach to disease. So this represents the most current algorithm for use in the United States. This is the ACC expert consensus decision pathway, which not only deals with return to play issues, but also with myocarditis as a broader entity. And as you'll see here, the recommendation for testing should really now be confined only to athletes that have true cardiopulmonary symptoms during infection, or true cardiopulmonary symptoms after infection, which would be considered during the post-acute sequela of SARS, or in those that are hospitalized with increased suspicion for cardiac involvement as diagnosed by troponin testing. And in these 3 small but important subsets, the triad test remains the number 1 go-to standard, with cardiovascular expertise consultation added to that. And in cases of abnormal testing, it is of course reasonable to move to the CMR because these are patients that have, again, an increased pretest probability of problems. So to conclude, COVID-19 infection and the athlete heart, should we be worried? Again, my answer is yes, but not nearly as worried as we once thought we should be. COVID-19, once thought to be a myocarditis public health problem, has evolved into a manageable clinical scenario with the 5 following steps. First, the recognized high incidence of troponemia among critically hospitalized patients led to concern among sports cardiologists and the general medical community about a future public health crisis among athletes. This led to very rapid and prompt development of PPE protocols designed to detect clinically silent inflammatory heart disease in this large heterogeneous population. This was followed by diligent and rigorous collection of widespread clinical experience, leading to a better understanding of the problem and once and for all credible prevalence estimates. This led to revision of protocols focusing only on the patients presenting with increased pretest probability inflammatory heart disease in an overall effort to allocate the precious resources we have at our fingertips to those that benefit the most. With that, I will conclude, and I very much appreciate your attention.
Thank you, Dr. Baggish. I'll now invite